So before KEYNOTE-061, we had randomized data that nivolumab was better than placebo in late-line treatment for advanced gastric GE junction cancer. And we had data that PD-L1 blockade was no better than chemotherapy in the third-line setting. So KEYNOTE-061 was the first time that anti-PD-1 was compared head-to-head in a randomized trial with chemotherapy in the second-line setting for gastric GE junction cancer. And it found that pembrolizumab had a shorter progression-free survival compared to chemo, yet somehow overall survival was comparable to that of chemo, but it did not show superiority of pembrolizumab over chemotherapy, so it did not meet its primary endpoint. But something that was odd about KEYNOTE-061 was that that progression-free survival was shorter in the pembro arm compared to the chemo arm, and yet the overall survival was similar between the two arms. And so the question is, why would the PFS be shorter and yet sort of catch up by the time overall survival happened? And since then, more trials have come out in this disease that showed a similar pattern in the survival curves, where the immunotherapy arm has a worse PFS, but then a comparable overall survival with a significant crossing over of the curves.